Posterior lenticonus is a congenital, progressive condition where there is thinning and bowing of a part of the posterior capsule of the lens. Unilateral cases are more common than bilateral. Central lenticonus is more commonly seen than the eccentric one. In early infancy, the lens cortex is relatively clear, and with time, the thin lens capsule bulges. The normal lamellar arrangement of the lens fibers become disrupted, resulting in cataractous changes in the form of dot opacity or a snail track along the posterior capsule, dehiscence of the posterior capsule with lenticular material in the anterior vitreous phase, eliciting the fishtail sign or sometimes a total cataract. In this video, we shall discuss the surgical tips for managing this condition with a morphological diversity. This is a 1-year-old boy presenting with posterior lenticonus. This surgical video demonstrates the intraoperative findings in this case. The room lights were dimmed, and under high magnification and under coaxial illumination, one can see the central lenticular opacity with a large crater in the center. A high molecular weight viscoelastic device was injected into the anterior chamber. The anterior capsulorhexis was initiated with the cystitome. The anterior capsulorhexis in these cases is relatively easier as the anterior lens capsule becomes flatter when the intralenticular pressure reduces due to either bowing or rupture of the posterior capsule. The size of the anterior capsulotomy should be adequate. The bottle height is lowered, the hydrodissection is avoided. The lens cortex is aspirated from periphery first, followed by central lenticular matter if there is no pre-existing capsular dehiscence. This is the pliable and thin posterior capsule, and the huge crater-like depression is the posterior lenticonus without defect. A single-piece acrylic intraocular lens was implanted in the bag. Primary posterior capsulotomy and anterior vitrectomy was completed with an automated vitrector. Another scenario with posterior lenticonus can present is with a pre-existing posterior capsular defect and a total cataract. In such case, anterior capsule is stained with trypan blue and anterior capsulotomy completed. A bottle height is reduced and hydrodissection avoided. The posterior defect noted with a lens matter in the anterior vitreous phase. In such cases, the central lens matter is aspirated first, preferably with a vitrector, followed by the peripheral cortex. Anterior vitrectomy should be done adequately, making sure there are no vitreous tags.
This is another example of a pre-existing capsular defect with a fishtail sign. After the capsulorhexis, the central lens matter lying in the anterior vitreous phase is aspirated first with a high aspiration flow rate, followed by the cortical lens matter.
A single-piece intraocular lens can be implanted in the back if the posterior defect is not larger than the anterior capsulotomy, or a 3-piece lens can be placed in the sulcus if the defect is larger than the anterior capsulotomy. This video highlights the tips and tricks of surgical management of posterior lenticonus, which are: keep both single and 3-piece intraocular lens ready, lower the bottle height throughout the surgery, avoid hydrodissection, and aspirate lens matter from periphery if there is no posterior defect and from center if there is a posterior capsular defect.